Okay, well, thank you very much for having me here once again. It is a great pleasure. As Professor Yankov mentioned before, we come from a 30-degree, it was 30-degree temperature when I left, and here it was very, very nice and soothing, but I always enjoy myself here. It's a very beautiful place. So I live now in Brasilia. So we have a partnership between the Brasilia Vision Hospital and LaserFocus, and all of you are invited to visit us at any time through Mirko. You can talk to him, and then it will be a pleasure. Right now, the Department of Cataract, we have 8 people in the staff, and we have a yearly fellowship, so that's very interesting. And I will be talking now about what should we know with keratoconus and intraocular lenses. And it is a tricky matter because there are several pitfalls and certain traps associated to keratoconus and cataract surgery. And although there isn't an actual rule of thumb, it is important to know the lens, and I will try to clarify this, what we should see the different characteristics of intraocular lens, and try to know as much as possible of the cornea of the patient. And that, in my opinion, is probably the trickiest part, because we do have certain limitations in the examination, although that has improved tremendously in the past years. But also we have to know what we will be treating, and we also have to try to predict the future. So the previous presentations were very valuable for us to know in which direction we are heading with the treatment of keratoconus and the evolution of keratoconus in order to present the best results possible. We can see here, this to me is the ideal patient with cataract. So a relatively young patient, we don't wait as long. We already intervene when it is starting to change the quality of life of the patient. But this cornea, which is essentially practically a spherical cornea, with very low astigmatism, we'll soon, I hope in the next years, be able to present our results with femtosecond cataract surgery, which is now becoming more and more a reality, although it still is in its infancy. But even with the manual techniques, we do have very good predictability and very low induction of astigmatism. So with an almost spherical cornea, I know that the result that I expect with intraocular lens will be very accurate. I will be able to predict this before the surgery. Now, things do get a little bit more complicated when we deal with this type of cornea, because the challenge here is getting the correct readings in this type of cornea, and that depends on the clinical status of the patient. Remember that we're dealing with elderly patients that have changes in not only in ocular surface but also in the tears. And also to establish not only the position that we see here in the exam, but also the real position while he's sitting down or laying down, because that will be crucial in order to determine the position of the lens that will try to treat this type of changes. So we'll be dealing with not only keratoconus, but with different types of astigmatism. In relation to the lens, and I hope to present some data according to this, but the toric intraocular lens and our greatest experiences with the Alcon intraocular lens, we're almost reaching 10 years experience with that type of lens. And this is due to the characteristics of this single piece intraocular lens with the relations between the haptics and the body of the lens, which do bring us predictability, stability, and that is directly associated to the lack of centration and to the lack of rotation of the lens. So with this lens, and we've been following it for several years, we know that in the position that you leave it inside the patient, it will stay there. So that is crucial in order to deliver adequate results and in order to expect certain results from the patient. This is a monofocal conventional monofocal and with a toric surface. In the past 2 years, we're starting to get experience with association of a diffractive surface with the toric surface. Now, although the diffractive surfaces for correcting presbyopia, for allowing a near vision to the patient, although we have been getting good results within its limitations, the challenge here, what the greatest question was, what would happen when this was associated to the posterior toric lens? In the beginning, before we started actually working with this lens, we were a bit insecure because since this brings down contrast sensitivity in certain light conditions, it's not the same vision, the same distance, the same far vision as a monofocal intraocular lens. We were a little bit insecure as to the association of both surfaces. So we did a retrospective review during 2012 of the first 65 eyes of 37 patients, and we presented these results at the ASCRS. And these patients presented cataract associated to the diminished visual acuity. Typical protocol study of these patients with a corneal astigmatism between 1 diopter and 3.39 diopters in this series. It is very important that the astigmatism is corneal. When we don't deal with these, with astigmatism, with correction of astigmatism with intraocular lens, we tend to look too much at the astigmatism, to the refraction of astigmatism, but it is always important to focus and concentrate on the corneal astigmatism because that's what we're correcting, and no other ocular disease associated. So we evaluated the near visual acuity at 33 centimeters and the far at the distance visual acuity. We evaluated corneal astigmatism induced with the surgery, which may occur. And we evaluated here the postoperative refractive astigmatism because we do want to, although we're treating the corneal astigmatism, we want as a final result the diminishing of the refractive astigmatism. So these patients, the age varied between, the mean was 66 years, they varied from 48 to 79 years. 57% of them were female, 43% of them were male. What we've been seeing is the percentage of females and males that they've been getting very close now for patients with these diffractive intraocular lens. So the preoperative astigmatism was an average of 1.5. This was before the surgery, and it varied from 0.75 to 3.39. Now the postoperative refraction in spherical diopters was a very good result in our opinion. Was 0.2 as an average, and it varied from 0 to 0.75. So this is directly related to the intraocular, to the biometry. So this we did this mostly with the IOL master. So this showed a good results in terms of the position of the intraocular lens. And the refraction of spherical diopters, it's important to note that 6 of the 65 cases, 62 varied from what we were expecting, and 3 cases were 0.075. Now the postoperative astigmatism of the cornea was 1.38. There was not a significant difference from the preoperative and postoperative results of the astigmatism of the cornea. However, the postoperative refractive astigmatism, we see a very significant decrease. So the postoperative astigmatism, the refractive astigmatism, was very close to 0. It did vary, however, from 0 to 1.25. If we break down the cases, we'll see that in 64 cases of the 65, the postoperative refractive astigmatism had a low variation, varied from 0 to 0.5. With 4 diffractive intraocular lenses, we consider this a good result, with the exception of 1 case, which had a 1.25 astigmatism residual. With these diffractive intraocular lenses, we want distance and near vision. The near uncorrected visual acuity varied about 0.03 logMAR, which is 20/20, for near vision. And for distance vision, the uncorrected visual acuity distance, it was also close to 20/20. However, we do see 1 case with 20/40. Breaking down the uncorrected visual acuity at a distance, of the 65 cases, 62 was around 2020, 2025, which we consider a very good result. 2 cases were 2030, and 1 case was 2040. And what is important to notice about this 1 case that was 2040, it was a case where there was refractive astigmatism 1.25. So these were our first 65 cases. We did see a very significant near and distance visual acuity improvement within the group, similar, practically identical to normal diffractive IOLs, to conventional monofocal non-toric diffractive IOLs. However, the cases that did not present such a good result were directly related to residual astigmatism. So the result, the performance of this lens was very good. The cases that we did not have a good performance were not related to the lens itself, but to the pre-calculation of the astigmatism, to the estimation of the astigmatism, and to the residual astigmatism resultant of an inadequate calculation. So the most important thing is to pay attention to eventual residual astigmatism, be prepared to treat it in these cases, and also pay close attention to the incision. In this table, we see here all the intraocular lenses of Alcon that are available. The other laboratories also have similar lenses that are available, and the range of coverage of each lens. And if we pay attention here, we see that the range is 0.5 diopters. However, if we take into consideration a diffractive toric IOL, we see that the range drops from 0.3 diopters. So these IOLs do demand closer attention, and they demand more precision coming from the medical doctor, coming from the estimate. We see surgery as I wish it were, and that spherical cornea with a 2.2 incision performed at a certain place where the incision will be, the induction of astigmatism will be minimum, and this would be the ideal surgery with minimum interference as possible in order to introduce diffractive intraocular lens. So this very small incision will induce very low astigmatism and will interfere the least amount possible in our surgery. This is another example of what I consider very good incisions, and from now on, and I expect to present this in the following years, these incisions will become more and more predictable, especially with what with the newer technologies available with femtosecond. So the challenges and what we should know with keratoconus and intraocular lens. So we can divide them in what we know about the cornea and what we know about the position of the intraocular lens. So although we will be dealing with astigmatism, with results with astigmatism, we must never forget that the most important calculation comes from determining the effective lens position of the intraocular lens. And this will come from the formulas that we have that are available. Now we tend to create a certain aura, certain beliefs about certain formulas, but I still don't think, I do not think that we have reached, we want very, very good precision. And we do have good precision, but we don't have yet perfect precision with estimation with the current formulas. But the main objective of the formulas that exist is to determine the exact position of where the lens will be, and that will determine in terms of the results in terms of spherical diopters. So we have 2 styles of formulas, and I don't think one is exactly better than the other, but it is important to know what the formulas bring in order to allow us to estimate, to evaluate the calculations, and if they're being adequate for that determined patient. So we use with more frequency SRKT and Harfer-Q formulas. The SRKT and the Holiday 1 mostly for higher axial length. So patients that have over 22 millimeters in axial length, 23, 24, we use the SRKT. And we use the Harfer-Q for lower axial lengths. So for patients that have 22 or lower millimeters in axial length. Now the main characteristic of these two formulas is that they are based on pre-established eye models. So they assume certain measures that are made within the eye. So in the case, and this is valid for both of them, so if a patient presents with a high curvature in the cornea, since it is based on a pre-established model eye, they assume that the anterior chamber is also higher. It makes sense that that corneas that have higher curvatures have higher axial lengths. Now, in the case of myopic LASIK, in case of refractive surgery performing myopic LASIK, we have a patient that has a high axial length because he's a myope. We have a patient that has, usually, since he is a myope, a high anterior chamber depth. However, due to LASIK, due to the refractive surgery, we have low curvature. Now the problem is that these formulas, SRKT and HARFA-Q, if they see a low curvature, they will assume that the patient has a lower anterior chamber depth. So they will assume that the lens is positioned further than it actually is. And that will create what is seen as residual hyperopia. And the same thing happens. So with a low, the same thing happens otherwise. In patients that have a low curvature, hyperopes with a low axial length, which is a characteristic of hyperopes, the formula assumes that they have a low ACD. However, if you perform a hyperopic LASIK, you will have a low axial length associated to a higher curvature that was induced by the laser. And however, with a higher curvature, the formula will assume that they have a higher anterior chamber depth, but in reality they have a lower anterior chamber depth. So that is a source of error. Now, the formulas that we tend to use in these cases, we know that in Europe, Haigis is used, at least from information that has been passed on, in almost 100% of the cases. But we have standardized Haigis and Holiday 2 for patients that have postoperative refractive procedures. And why is that? Because they don't assume the anterior chamber depth. They get the measurement of the anterior chamber depth, which is obtained by the IOL master and LensStar, which perform biometry from interferometry. So instead of assuming a certain anterior chamber depth, they use the direct measurement of the anterior chamber depth and reach a result. Now this is very interesting and this seems very logical. However, we don't see Haigis and Holiday 2 working for every single case. We see a high rate of success also with SRK2, with SRKT. The message here in terms of effective lens position is to know what these formulas bring and then try to evaluate according to each case. And this is especially true for the keratoconus, because the keratoconus you have very different curvatures, you have very irregular stigmatisms, or astigmatisms that may vary in their irregularity, and you will have different anterior chamber depths. So what we do now in all of the cases is we know the theory behind all these formulas, but we still print out each formula, every single formula for each patient. That way, with all formulas in front of us and with the clinical data of the patient and the status of the keratoconus, we try to estimate the best possible effective lens position. So there isn't a real rule or the best formula possible for all cases. But it's important to know what each formula brings in order to achieve the best possible result. And we have to do this on a case-to-case basis. So the effective lens position is extremely important in order to achieve the best spherical diopter possible results. However, once again, for keratoconus or for astigmatism, we always have to focus on the cornea. It is more important than the refraction. So in focusing on the cornea, we have to focus where we're going to treat. And I've showed in previous presentations here how we try to mark the cornea. And this is one marker that we've used frequently. And this marker is interesting because after marking it with normal transplantation pens, we're able to connect this to a tonometer, to the IOP, to the Goldman tonometer. So this theoretically allows for good positioning in front of the patient. We attach it to the tonometer, and on the tonometer itself we have markings, and here we can either mark 0 or 180, so we have a general idea of the position of the eye when it's laying down, or we can just mark the position of the incision or mark the position where the intraocular lens will be. So here we have the lens have to be at a position at around 10 degrees. At 10 degrees, we can set it up here at this marker, and then we bring it to the patient. Now, on the video it seems nice, but this does bring a certain degree of discomfort for the patient. It's not exactly ideal. We have other markers in the market. This one, the Nuhan one-step. It can be done without a tonometer. It can be done without the slit lamp examination, and you can control it with a fluid level. So this theoretically allows for a good coordination with the patient. However, this situation here I also do not consider ideal. Dr. Akahoshi, he has a digital level. So with inclination you'll see different lights here. This one of the services here in Brazil, I had a chance to use one of these. So it beeps and it shows when it's there. However, it is still pretty clumsy. It still is not ideal. It looks very fine in the video, but we all know that different patients react differently to these devices that come very close to the eye. So what we do now routinely is try keeping it as simple as possible. So what I do now is just mark with a pen exactly where I'm going to put the lens and where I'm going to make the incision. I find this a little bit more comfortable. We use a specula. We don't use the hands here. This patient was very cooperative. But we find this the easiest and more reproductive system so far. Now Alcon has come out, and this will be followed by several other laboratories with a Varion system. Now the Varion system I find is theoretically very attractive. We haven't had this in Brazil. This came out now in the SCRS. But the whole idea is photographing the eye, photographing certain landmarks that are specific to the patient. And to me, what is more interesting is being able to use this data, be able to include the planning of our intraocular lens, and then this is transported directly to the microscope itself as an interface. Now I haven't had a chance to use the Varion system, but I did use the Zeiss system, the Callisto system, and it is strange initially for the surgeon, because you have, while you're operating, an interface floating between the eye and the vision that we have. But you get used to it after a while, and then it'll allow you to guide your incision and also to guide your intraocular lens. And all this in real time. So you still use markings, but then you'll be able to, and here you can determine the size of the incision, you can determine the position of the incision, and the position of the lens. So this, I think this is a very valuable tool. I think this will be part of our reality in the future, in the next few months, next few years. The cost inevitably will go down of this equipment. There will be more competition. But I think this real-time interchange of data of the actual patient and of what we're planning for him, I think will be this associated also to femtosecond and automatic capsulorhexis and automatic incisions. I think this will be the future of the surgery and will allow us to become more predictable, to have more predictable results. So here we have another example of the Varian with another intraocular lens. So there's real-time tracking. So what I see now is the convergence of the technology that we've had for several years with refractive surgery, also coming in with cataract surgery until it's all one field. So this I wanted to bring it. This is still example from other surgeons, but I hope that in the next years I'll be able to show our own examples. This shows association of the Varian with the LensX system. We'll have access soon to several femtosecond systems that we haven't reached an ideal. But to me, one of the most attractive parts of a femtosecond system is being able to measure the eye or get a tomography, get an OCT in theoretically real time. With a LensX, it's not really real time because they capture the image, but then they freeze the image, and you make your surgical plans from there. But we see this in other devices, and I think this will be the tendency to be able to measure all of this in real time. And I can see this applied to other fields such as cross-linking and refractive surgery. So in terms of keratoconus and intraocular lens, it is very important to focus on the cornea. With normal regular astigmatisms, the refraction is important as clinical data, but not for your surgical planning. However, for the keratoconus, the refraction becomes important because we're dealing with patients that don't have a very good quality of vision. So we have to be careful to not treat a certain aspect of the cornea, to try to treat a certain aspect of the cornea, but then not obtain a very good result. The problem is if we use toric intraocular lenses to treat keratoconus, and the keratoconus is not stable or will be treated further on with a transplant or other surgical technique, the problem is that what you put inside the capsular bag will be there essentially forever. So if you have to change, if the cornea goes through a change, or if we have to induce a change through transplantation or through surgery, or even through contact lenses, then we cannot forget that the intraocular lens, the power, the toric power that is in the intraocular lens will be totally manifest or maybe even worsened. So we always have to take that into consideration when we are dealing with keratoconus. As a rule of thumb, one good way to see if your treatment will probably be effective is to try to correlate, then in this case, the corneal astigmatism with the refractive astigmatism. So as an example, if I have a corneal astigmatism, a very irregular keratoconus, but that has a certain astigmatism at a certain axis, if the refractive astigmatism corresponds to that axis, then there's a good chance, with a good visual acuity, then there's a good chance that I will have a good result with the treatment of the keratoconus in that situation. However, if I do have a refractive astigmatism that correlates to the corneal astigmatism but with a low visual acuity, then that should raise some questions as to if I'll achieve a good result or not. So these are very important points with keratoconus to when we approach these cases with cataract. Another point really is the stability of the keratoconus. So it is important to try to establish if the keratoconus is stable enough to allow for a good result for several years. And once again, to be very careful with toric intraocular lens. Although they may be very effective as treatment, as treatment for astigmatism, we have to be careful with the fact that it is permanent and it will be there. So changes to the cornea different from what was planned will lead to worse results with toric intraocular lens. In the end, as I said, we must know the patient, we must know the cornea and the intraocular lens, but we have to treat it case by case. So I have some cases here of keratoconus and irregular astigmatism that I would like to present, and then we'll be able to discuss them in more depth after the next break. So this patient, when the toric intraocular lens, when it came out on the market, this was keratoconus was formally contraindicated for this type of lens, but certain patients presented with a chance to be treated. So this was our first patient that we were able to treat with a toric intraocular lens. It is a 64-year-old female. She was diagnosed with keratoconus since 1997. However, she was starting to present intolerance to her rigid contact lenses. At the time, she had a visual acuity of 20/25 with this refraction, hyperopia with a not very high astigmatism at 60. Same thing with the left eye, 20/25 with a very similar refraction to the right eye. So in 2007, she started complaining of low vision of the right eye. She presented with a cortical anterior cataract, and the right eye had more cataract than the left eye. And her visual acuity did decrease from 20/25 to 20/50, although the refraction hadn't changed very much. And this is when she started becoming intolerant with contact lenses. So this is just to have an objective data, just so we can present it here. This was done about 6 years ago. So here it shows a refraction, and here we see the topography showing a typical keratoconus. And this, at the time, was seen as a contraindication for this type of surgery. However, we try to focus on what we see in the middle, in the region of the pupil approximately. And we can see that the stigmatism on the cornea, we can see a certain bow tie standard here if we ignore this part here on the bottom. And it does correlate approximately to the refractive astigmatism. And that associated to a good visual acuity that we saw before led us to the treatment with a toric intraocular lens. So our plan was to allow for the lens to be well aligned with this astigmatism, with the central astigmatism that we produced. In this case, we did obtain a very successful result. So this was an auto-refraction, but it did correlate with the clinical refraction later. And further on, she operated the other eye with good success. So this opened up a whole new path for the treatment of keratoconus. This patient was elderly. The keratoconus was stable for several years. But, and I will always present this and we'll discuss this later, if there is a change, or if there's a change in the cornea, then we'll lose this treatment with the toric IOL. And also, as a reminder, if we try now after surgery to put a rigid contact lens, what will happen is that the rigid contact lens will correct the stigmatism of the cornea, but it will manifest completely the stigmatism that is present in the intraocular lens. So those are some cares that we have to take. But in these cases, in certain more irregular astigmatisms, it has opened a new path for us to follow. This patient, also female, she was 72 years old. She had worn a rigid contact lens for the past 20 years and started to present with a cataract, grade 2 cataract. Her refraction was more extreme. She had very high myopia, very high astigmatism, as we'll see. She wasn't ever able to wear glasses, but her visual acuity with contact lenses now was 20/60 and 20/50. She presented with a more extreme case, and this would more than a keratoconus, I think, would be more likely of a pellucid degeneration. But it follows in a similar category to the past patient, if we try to focus on the stigmatism here. So typically we see this image with a pellucid marginal degeneration, but we hoped and we expected that a toric intraocular lens would treat this. We don't see the numbers here, but it was over 6 diopters of astigmatism. Here we see one of the final stages of the surgery, which is the positioning here of the lens. And in this case, the result here was an uncorrected visual acuity of 20/50 and 20/40 without contact lenses. We weren't able to refract this. We weren't able to improve this with glasses. In this case, the patient was very satisfied with this vision because it was a little bit better than the vision that she had with contact lenses of a high diopter, but this allowed her for a day-to-day independence. What made us go for the treatment with a toric IOL rather than a conventional IOL and a transplant or treatment of the cornea is that for a 72-year-old patient, going through a corneal transplant for both eyes would mean higher recovery rate. It would be harder for her, more difficult than a toric IOL. But we do always have to deal with the fact that the cornea may get worse. This was a T9, this was a high astigmatic toric IOL, and in the eventual case of transplantation or any other treatment on the cornea, we would probably have to remove this intraocular lens. This other case is a younger female. She was 48 years old. She had a retinal detachment operated in 2011, and with very good result. But she presented with this refraction of -4.5 and -475 of astigmatism with a good vision. However, after 2 years, which is typical, typical with retinal detachment and vitrectomy, she started to develop a cataract. And she had one characteristic, which was a low endothelial cell count. In the right eye, she had 1,300 cells, and the left eye 1,000 with the same number. So it was probably a dystrophy and a low count on both eyes. Her refraction had maintained, however, she had 20/40. Here we can see in the topography, she does not have an irregular astigmatism. A little bit asymmetrical here on the top, but she does have an astigmatism that can be treated with a toric IOL. The great problem here is that she has a very low cell count, a lot of guttata, and she was very young. So there was a perspective here of a future treatment of the cornea, very probably a transplantation to be performed maybe 10 years or 15 years from now. So in this case, we did, as I said, we used HIGUS here. We saw, I'm sorry it's not very clear, but the intraocular lens had 12 diopters. We compared it with SRKT. We saw good correlation, also with 12 diopters. But our conduct was a little bit different. We did not choose the toric IOL, a pure toric IOL. What we did was associate the 12 diopter IQ lens with a supplemental lens, which is known as a sulcoflex, which is a lens that goes into the sulcus. It is much thinner lens. It is ribbed here so it doesn't rotate, and we've had a good experience with these lenses in the past years, so we have seen good stability both in rotation and in centration. So the whole concept here, it's a do-it implantation in which we already see the previous IOL and then the implanting of the supplemental sulcoflex, the supplemental sulcus IOL over the previous intraocular lens. So in this case, we used a toric sulcoflex, a toric supplemental lens. It's been called a do-it procedure with two lenses. And this was done recently, and 40 days post-op, we also obtained a result. This would be expected with a conventional intraocular lens. But the fact it was such a low cell count, we use a supplemental IOL because, and we have several cases, it is a very easy lens to remove. So this was another situation. This is not the same patient, but in which the sulcal flex had to be removed. And you can see, and this is for several years, it can be removed very easily. So in the event of a future transplantation or any other changes to the cornea, we remove the lens and we treat the cornea. So I do believe, we don't have that many cases, but I do believe that use of supplemental intraocular lens will be a great value when dealing with keratoconus. Here we have another case. This is a 57-year-old female. She also has been living with keratoconus for 30 years. Actually started to develop in the left eye, only in the left eye, a cataract that brought down her visual acuity to 20/40. In this case, we can see that we can see her keratoconus here. She has been very well adapted to intraocular lens, so the use of intraocular lens was not an issue for this patient on the left eye. She was going to continue using contact lens on the right eye, and she was prepared to continue to use a contact lens on the left eye. So in this case, and this is what we think is a bit different for the situation, we opted for the phakic emulsification to treat the cataract, but we use a diffractive intraocular lens, conventional, monofocal, non-toric diffractive intraocular lens. This was her refraction after the surgery, but with adapting a new rigid contact lens, then we obtained a similar result to what we usually get with other patients. We'll be able to discuss this also after lunch. And finally, this is a complex case. I'll go through and then we'll have a chance to discuss it with greater detail. But a 52-year-old female, she had operated 14 years ago with an artisan in both eyes. She had +5 and +7 as a refraction. Her uncorrected visual acuity was 20/60. It was 2200 on the left eye, but she was an amblyope. This would not improve, although it had been operated also. The refraction on the right eye was plano with some astigmatism, and then she reached a correct vision. But she was complaining of this uncorrected visual acuity, and she was complaining that now at 52 she couldn't read anymore. The problem here was that she did have also a low cell count. So this is also a ticking bomb. And we know that operating a cataract ahead of time will lead to less damage than if we wait a little bit longer. The initial plan for her was removing the artisan lens and implanting a lens, a conventional monofocal non-toric IOL, non-diffractive, of 29.5. The problem with the artisan is that being a rigid lens, this is another case but it's similar, we have to make a large opening. So it's hard to program a diffractive IOL. We don't know what the stigmatism here is going to be. However, the removal, although it was 14 years, the removal of this type of lens is also, I'm sorry, it's not very clear, but it's still pretty unconventional. The big problem is having this large incision. So this was a refraction after the surgery, which for the patient didn't make much of a difference because she still had this refraction. She'd had this vision beforehand. Her uncorrected visual acuity was also 20/60, but we were worried more about the endothelial cell count. And this was her topography after surgery. So what we did here was perform, we did at the time conventional LASIK, but I'm pretty sure she would benefit tremendously, a lot more in terms of quality with a topography guided LASIK. And after that, we introduced the sulcal flex, but this time a multifocal sulcal flex. So this was along the course of 2 years. We waited until the cornea was stable, we applied the laser, and then we implanted a supplemental multifocal intraocular lens. The only limitation that I see with a supplemental intraocular lens is that the multifocality comes from refractive circles, which I don't believe is as efficient as diffractive circles. However, this patient having one eye, with amblyopia in the other eye, she knew the limitations of the surgery and of the lens, and she became quite satisfied. Once again, with supplemental IOLs, to me, the main advantage is being able to remove them. I think they will be one of the great tools we'll be able to have in treating keratoconus and treating corneal problems or other problems, because we can always go back to a normal state. This patient had very good results, and we'll be open to discussions or any questions now. Thank you very much. This is for the continued education. It is related to the Higas and the Holiday formula. And in relation to the Higas and the Holiday formula, A, does it use a pre-established, it uses a pre-established eye model? Or B, does it use a measured anterior chamber depth from certain devices? Or C, it does not give effective lens position? Wait, I'll get it back. Just one second. Just one second here.